I think that really the challenge for us, this decade and maybe the next decade as well, hopefully not for too long, is to figure out which individuals who don't yet have symptoms we should be treating. And this is because we know that once symptoms are developed, even if Waldenström's is relatively indolent, really the quality of life decreases and our patients' lives are affected. So perhaps by intervening early, we could achieve even cure. And this is a conversation that's been occurring in parallel for patients with asymptomatic myeloma as well as patients with asymptomatic Waldenström's, because for many years we've been thinking that the diseases are similar in ways, although very different in other ways. And so in this meeting, I tried to summarize what we know about the risk stratification of patients with asymptomatic Waldenström's. And this is from work from both our group as well as other groups like the Mayo Clinic group, our colleagues from Italy and Spain, et cetera. And so I essentially discussed the model, the risk stratification model that we developed and published back in 2019, which leverages 4 parameters. We have bone marrow infiltration, we have serum IgM level, we have beta-2 microglobulin and albumin, and we made that model available at the time as a web application at awmrisk.com. It's entirely free to use for both clinicians and patients. And this meeting, I was actually able to share some statistics on its usage, and we saw that really there's 11,000 users, I think, and 15,000 sessions, if I remember correctly, really from all over the world, which was really encouraging to us, and it just shows that people are really hungry for a risk stratification model for our patients. It's important to them and it's important to us. And so I also showed data, again, both from our group and other groups, on the importance of MYD88 as well as CXCR4 mutations on the risk of progression to overt Waldenström's. And so although, the jury is still out, so to speak, I think the data seems to suggest that wild type status for MYD88 as well as CXCR4 mutations are associated with increased risk of progression to overt Waldenström's. And I think same is true actually of deletion 6q, and the Spanish group presented great data on that. But really, we need more data to reach a conclusion. We also need harmonized ways of detecting these alterations, because as each group, uses different methods, it just makes it much harder to integrate across multiple cohorts and really, be powered enough to answer these questions and to validate potential answers. So I think the jury is still out, but I think we're on our way to answer these important questions. And I am looking forward to seeing clinical genomic models of progression for patients with asymptomatic Waldenström's, similar to what we have started seeing in patients with asymptomatic myeloma. Furthermore, I presented some new data on bone marrow immune profiling for patients with asymptomatic Waldenström's, and that's all work funded by the Robert A. Kyle Award from the International Waldenström's Macroglobulinemia Foundation, because the next frontier is how can we move from clinical genomic models to models that also include biomarkers that speak to the capacity of the patient's immune system to respond to the tumor. And so by profiling immune cell composition in the bone marrow of patients with asymptomatic Waldenström's, we saw that despite the absence of symptoms, many alterations in immune cell composition are already present. This is similar to what we have seen and described before in patients with non-IgM MGUS and asymptomatic myeloma. But we also see that the types of immune dysregulation differ between asymptomatic Waldenström's and asymptomatic myeloma, which again highlights this difference in disease biology between the two entities. We also see that patients with minimal bone marrow infiltration, patients in whom we only know the disease exists through deep mutational scanning and an M spike, seem to have similar changes in immune cell composition to the ones that have measurable bone marrow disease burden. And I think that's important because it raises the possibility that perhaps the infiltrate was not minimal after all, perhaps due to patchy infiltration and or spatial heterogeneity, we have just missed it. But it also raises the possibility that immune dysregulation is established early in the oncogenesis. And when thinking about early intervention and disease interception, progression interception, one gets very excited about a finding like this because it suggests that if we could intervene early, perhaps with an immunotherapy regimen, we could change, alter the course of disease. Lastly, we looked at the impact of concurrent clonal hematopoiesis on the bone marrow immune cell composition. And we found that patients with asymptomatic Waldenström's and concurrent clonal hematopoiesis present changes in granulopoiesis, changes in erythropoiesis, as well as a pro-inflammatory phenotype in monocytes. And the data really provides a possible mechanism behind the association of concurrent clonal hematopoiesis and the risk of progression we see in our patients. But it also reminds us that we really need to do more work to deconvolve the risk of developing cytopenias, towards which both the tumor and concurrent clonal hematopoiesis may contribute, from the risk of true tumor progression.